Yeah, thank you for giving me the opportunity to share my work in Belize. Today I'm going to talk about capacity building versus short-term medical volunteerism for rehabilitation in Belize. Let me get my thing here. There we go. And just nicely summarize who I am. So the plan for today is to talk about disability and rehabilitation in the context of Belize, and just begin to explore the challenges associated with volunteerism and capacity building in the context of building capacity in the rehabilitation sector in Belize. For those of you who aren't familiar, Belize is a small little country nestled in Central America in between Mexico and Guatemala. Population is about 400 to 450,000 people. And it's the only English-speaking country in Central America. So I've won some bets with that little factoid. But it's a beautiful country. It's very diverse in many ways. It's known for its white sandy beaches, but about 50 miles, less than 50 miles west of those sandy beaches, you have the beautiful Mayan ruins nestled in between the rainforests of Central America. And it's a very rural country with over 60% of people living in rural villages, which poses a lot of challenges to accessing healthcare and rehabilitation, as you can imagine. So I want to kind of start out talking about disability and kind of setting the context of disability. And I want to start out kind of on a macro level. So there's estimates that approximately 1.3 billion people live with some sort of long-term disability. And this equates to about 16% of the population, or 1 in 6 people. And I want to emphasize this as long-term disability. So this doesn't account for people who have acute low back pain or might have just had surgery or have some type of medical condition that results in a temporary short-term disability. This is people living with long-term disability. And often this group is referred to the world's largest minority and also the missing billion. Because as we all know, people with disabilities, especially in lower middle income countries, they often are not provided the means to live a fruitful life in a lot of ways in terms of gaining education, employment, and that type of stuff. So they're often marginalized in their communities. And many think this number is growing for a variety of reasons listed here, including the population is aging in a lot of countries around the world. As a result, non-communicable disease rates are increasing, and people experience a lot of disability as a result of non-communicable diseases, and even communicable diseases. And you think about COVID and some of those conditions, often people struggle with long-term disability as a result. So this number is increasing, and it's a major problem around the world. And as we all know, disability, people who are disabled are in increased risk of poverty, which makes them vulnerable in their communities. It just develops into this vicious cycle it's really difficult to get out of. And it's even more magnified in low middle income countries. So in Belize, I call it the unknown reality. We all know people live with disability in Belize, but we really don't know the scale of it. And this is for many reasons. The statistics related to the prevalence of disability is just not known. There's no national registry for people with disabilities. The Statistical Institute of Belize is underfunded and understaffed. And there's just a lack of expertise and even political will to really measure and study this problem in country. And so they rely on their census studies that happen every 10 years. And even these census studies, basically, they have 10 questions that they ask the head of the household. Does anyone in your household have trouble walking? Does anyone have trouble dressing? Those type of real generalized questions. And so there's really not a clear understanding of the prevalence of disability and the magnitude and the impact on the individual and the family and the communities as a whole. And they really, Belize relies on statistics collected by UNICEF and Pan American Health Organization, and entities like that, which are really kind of generalized statistics. And this is just a common problem, not unique to Belize, but it's common around the world. A lot of countries just don't have an accurate understanding of the magnitude of disability in their country. And so a lot of people say you value what you measure, right? If you value something, really want to know about it, you measure it. And like I just said in Belize, they're not measuring this. And so they don't value the data right now. And it's reflective in how they've kind of operated over the years. Beginning back in 2020, The government was looking for ways to cut their budget, and they ended up dismantling the Ministry of Human Development's Disability Services Division. And this really kind of washed the government's hands of getting involved in the lives of people living with disability in Belize. A few years later, the International Disability Rights Monitor listed Belize as one of the least inclusive nations in the Americas with regards to disability. And there's a little bit of hope in 2011 when Belize signed and ratified the UN Convention on the Rights of Persons Living with Disabilities, which just ensures the rights of persons with disability are preserved. And the reality was that they signed it, but really didn't do much with that, unfortunately. In 2017, Belize did a voluntary national review of the UN Sustainable Development Goals, and they actually identified a serious shortage in certain specialties and listed physical therapy as one of those professions. So they finally acknowledged it, that it's just not sufficient and more needs to be done. And around that time, Belize did start recognizing physical therapy as a profession, basically by giving out licenses to people who are trained in physical therapy around the world. And so at least they started recognizing physical therapy as a profession. They started giving out licenses, and some momentum was gained. But that's about it. And as you see in this next slide, currently there's still no uniform definition or classification of disability in Belize. There's no laws preventing discrimination in employment based on disability. The Belize Building Act doesn't require specific international building standards for accessibility and guidelines for persons with disability. Like I said, there's no national registry, and there's just no investment from the World Bank and other larger entities around the world in projects focused on disability inclusion. So there's just not a lot really being done for persons who live with disability in Belize, unfortunately. So when you think of disability and what can be done for people, you think of rehabilitation. And so again, to back out a little bit on a grand scale globally, there's estimates that 1 in 3 people need rehabilitation at some point in their medical condition. And in fact, there's a study published in The Lancet in 2019 where they did global estimate of the need for rehabilitation based on the Global Burden of Disease study. And they found just in 2019 alone that they estimate there are 2.45 billion people that had some sort of medical condition that could have benefited from rehabilitation. So this was just kind of a study that really opened the eyes to the need for rehabilitation. And combine that with other findings such as the one listed here by WHO, that especially in low middle income countries, they average less than 10 skilled rehab practitioners per million people. So there's a huge need for rehab. It's unmet, and it's recognized by the World Health Organization. In 2017, they had a call for action for this unmet need for rehabilitation globally and charged countries with doing more for the people living with disabilities. And this was a big statement by WHO. They never really identified disability as a major problem and rehabilitation as a major need. And this was the first big statement that really has set in action some great things that are being done around the world. But in Belize, unfortunately, as you probably can assume, there's not a lot being done in the rehabilitation side of things in country. I was able to do, in 2020, I was awarded a Fulbright scholarship to go down and do a workforce analysis for rehabilitation in Belize. I partnered with the U.S. Embassy, the University of Belize, to really try to get a solid understanding of what the workforce looked like. It was unknown. It was unknown by the government, by the Ministry of Health. It was unknown by the Pan American Health Organization, some of the regional entities, and no one had really studied this. So I was able to go down for a few months and take a look at the situation, and these are just some of my findings that I'll highlight. Essentially, again, out of 450,000 people, there are 18 people that were formally trained in physical therapy, and 16 of them identified physical therapy as their primary source of income and their profession. And to give you a little comparison here, there's 412 medical doctors in Belize and 797 registered nurses in country. So obviously, the workforce is diminished and not what it needs to be at the national level. Of these 18 people, 6 of them, they're native to 6 different countries. A little over half were actually from Belize. All of them trained outside of Belize because there's no training programs for any of the rehab professions in country. And most of the people working, they have their own private practice, or they do a home health practice, because that's where the money is. It's that private sector that can afford the physical therapy services. And so I found out that only one person works in acute care in the National Hospital, and only one person works on Saturday mornings. And so this just kind of shows that there's just not a lot being done from a rehab standpoint in country. In addition, there's no occupational therapists, there's no prosthetists or orthotists, there's no physiatrists, and speech language pathologists are just now starting to work in Belize, but it's in its infancy. And task shifting is not feasible, right? Asking the nurses, asking other medical providers to take on some of the responsibilities of a rehabilitation specialist, it's not feasible. They're burdened and they have enough work to do themselves. To take on this added training and responsibility is just not feasible. So there's just not, from a government's perspective and from a workforce perspective, there's really poor access to physical therapy and other rehab providers in Belize. In 2017, Belize did the national review of the Sustainable Development Goals that I mentioned earlier, and they identified a serious shortage of certain specialties such as physiotherapists. And they admitted that it severely restricts the quality and quantity of services being provided. So the government recognized this and they noticed it, but unfortunately, the Belize Ministry of Health and Wellness Strategic Plan on Human Resources for Universal Health for 2019 to 2024 had no mention of physical therapy, occupational therapy, physiatry, prosthetics, etc. And so while they identified a need back in 2017, they really didn't create any sort of strategic plan to address the need at a national level, at least during this 5-year span through 2024. And it's a big problem. So what is the government doing? And this is where the volunteer and the international community comes into Belize. The government has bilateral agreements with countries such as Cuba and Nigeria. They actually pay for individuals, medical professionals, to come work in Belize for certain periods of time. And they have brought in physical therapists from Cuba to work for a year or two with different institutions. And they also have, they invite some of these medical brigades that will come in for short periods of time and provide a variety of different services for the health system. In particular, it's like surgical teams. They assisted with the response to COVID and things like that. But they have these agreements in place to have foreign assistance within the healthcare system throughout all aspects of the healthcare system, including physical therapy. And then there's just a robust volunteer industry that the government allows. And they allow short-term volunteers, foreign non-governmental organizations to set up shop in country with very little oversight. In 2020, when I was doing my workforce analysis, I was able to sit down with the licensing and accreditation unit to learn more about their work. And at that time, they only had 3 employees. And they were responsible for overseeing all the medical professions in Belize. So if you think about it, I listed over 1,000 nurses and MDs that they were responsible from a licensing and accreditation standpoint, in addition to other medical professions like pharmacy and nursing, pharmacy, social work, et cetera. In addition, they're supposed to be overseeing all the volunteers that come into country. Volunteers technically by law are supposed to register with the government, and it just doesn't happen because it's just not possible. They don't have the man and woman power to manage this. And so volunteers are coming in, and it's like the wild, wild west in a lot of ways. They really do whatever they want to do, wherever they want to do it, however they want to do it, with not much accountability, unfortunately. And again, the Belize, that strategic plan on human resources that I mentioned, they recognize that this dependency on foreign intervention, there's a lot of challenges associated with this practice. And the government recognizes it's not sustainable long-term. But unfortunately, they don't have a lot of plans in place, at least from a rehabilitation standpoint, how to make change in this. And so the problem with volunteerism is there's often a flawed assumption that these programs are relatively innocuous and provide mutual benefit. There's just a lot of research talking about things like potential to reinforce negative attitudes, disrupt community relations and dynamics, and even provide inappropriate or poor quality of care, and sometimes even harm to the people that they work with. And there's just a lot of research, there's a lot of commentaries, there's just a lot of things that speak to the inherent risks of volunteerism, especially when working with vulnerable populations. And this is domestic and international as well. And you can see this list of all these different things that are highlighted in the research. And in particular, if you think about it, a lot of people, when you go into communities that you don't speak the language, that's a big problem. There's so many cultural barriers involved as well. A lot of times people don't know the healthcare system and how to navigate it, and it just causes a lot of unnecessary risk and risk for harm. Unsustainability of care. If you think about it, if you have a team of people that come down and you see tons of patients, like what happens to these patients when you leave, and who sees them, and how can the healthcare system accommodate those people? And there's a proper follow-up care set in place, and oftentimes there's not. And ultimately, there can be a dependency on this foreign assistance, and some of these smaller communities are really under-resourced. And there was a lady that I met who was an anthropologist, and she was doing some research looking at the attitudes of the younger generations of the Mayans in southern Belize, and their attitudes towards their traditional medicine and their traditional approach to healthcare, and how they felt in relation to some of the medical providers, the international medical providers that come into their community to work. And they were finding that the younger generations were losing faith and confidence in the traditional approaches to medicine. And they viewed those volunteers that came in as the experts, and that they would be willing to wait for those people to come back at a later date rather than seeing their provider immediately to take care of things, or their traditional provider to take care of things up front. So there's just a lot of potential problems associated with this. And I have a few examples that highlight these first few points that I wanted to share with you all. So I worked with an organization that I'll talk a little bit more about later called Hillside Healthcare International. And Hillside Healthcare International is a foundation based out of Milwaukee that funds and operates this clinic in the southern aspect of Belize. And we work with the Ministry of Health, and we're assigned particular villages in that southern district to go to on a regular basis. So these villages expect us on a set schedule, and they're prepared for us when we arrive. Well, one time I went into a rural village, and I came across this 35-year-old male that had a post-transtibial amputation due to a farm incident. And he wasn't working, he wasn't able to work, wasn't able to provide for his family. It was just in a tough situation. And a few weeks before I arrived, there was this short-term mission team from the United States that just happened to bring a prefabricated prosthetic leg. And whatever image is popping into your head is probably accurate. It was one of these kind of old school prosthetic legs that was probably in a warehouse or a basement room somewhere in a hospital, that this team just thought, hey, let's bring it, see if we can find someone, that needs a prosthetic leg, and we'll give it to them. And by golly, they actually found a village in rural southern Belize that had a guy that needed a prosthetic leg. And this team didn't have any physical therapists. They fitted him with the prosthetic leg. It didn't fit real well, but in their mind, it fit well enough. And they helped him, trained him to walk for a week, and he was able to walk around his house at that time. And then the team left. And I'm sure to this day that team still is probably amazed at how they were able to help someone walk again. But little did they know, that guy, the wounds got infected, and he became septic, and our medical team ended up emergently transporting him up to the National Hospital for care. And fortunately, he turned out all right. Everything, it was a good story in the end. But to this day, I guarantee that short-term team that came down have no clue of what happened to that guy, and don't realize how bad they left him. And so this is just an example of not working within the healthcare system, collaborating with your in-country medical partners, and really trying to set up follow-up care when you leave to prevent things like this from happening. And so the negative ramifications on the individual level can be pretty harmful if not done well. To go out a little bit larger, this is another example, similar situation where I go into a community that we were assigned to, and the local pharmacist approached me, was just irate. He was just really frustrated and kind of taking it out on me. And I was like, what's going on? He's like, this American medical team came last week and they doled out a bunch of medications to all my patients with diabetes, hypertension, worms, etc. And they gave out medications for a month or two. And he goes, what am I supposed to do? That's my income. That's my source of income. I no longer have a source of income for the next couple months. And that's what I rely on to put food on the table for my family. And I just shook my head and I was like, I'm so sorry. I don't know what to say. That's not right. And you were wrong. And I apologize on behalf of my fellow Americans. But again, just another example of how our impact as volunteers can be both positive, but it can also be detrimental on not only an individual scale of the patients we work with, but even at the larger community level. And I'll just zoom out even further. The work that I did during my Fulbright study, I really got to spend a lot of time talking to people and really kind of understanding the situation. And what I learned was a lot of people believe that the government dismantled the disability section of the Ministry of Health because they had a scapegoat in the volunteer industry. They felt like that the volunteers were sufficient enough to meet the needs of people living with disabilities in Belize. And as a result, they could cut that budget and spend the money elsewhere because the volunteer industry was meeting their needs, when in reality, they're not, and they weren't. And so in some sense, you could argue that this volunteer industry disincentivizes the government in certain ways. And it really, again, causes potential problems at a much larger scale, even at a national level. So volunteerism is complex, it's necessary, but there's just as much risk for negative impact at an individual, community, and national scale as there is as a positive impact. And we just need to realize that and do the best we can at avoiding these negative situations when able. Another issue is practices outside the scope. Here are a couple studies that were done. The first one on top there was a published study in Lancet done by Dr. Ashley Dubé-Prasad out of Northwestern in Chicago. They did a survey study where they surveyed medical students, residents, and physicians. And they wanted to find out what the prevalence of persons from high-income countries traveling to low-middle-income countries to volunteer. What's the prevalence of them practicing outside their scope of training? At that time, I was working down the hall from Dr. Ashty, and I was able to adapt a similar study to the physical therapy profession where we surveyed a bunch of physical therapists. And both studies identified anywhere from 30 to 40% of participants in these studies admitted to practicing outside their scope for many different reasons. But the common themes you heard was that the volunteers felt like they had to do something. Something was better than nothing. And they felt a sense of urgency of doing something. They also didn't want to disrupt the relationship with the host. They felt like there's an expectation on them that they had to do something, even if it's something they wouldn't even do back home. I wouldn't travel to Iowa to practice as a physical therapist, even though I'm highly qualified to do so. I just wouldn't do it. So why would I travel to Belize or Africa or other places and practice? There's just a disconnect here. And so these studies pose some really challenging questions as to what are we doing? Why are we doing it? Is it right? And we need some introspection here as professionals to really think about what we're doing and how we're doing it. And so fortunately, there are organizations out there really exploring these ethical issues related to volunteerism and global health. One in particular that I'm part of and do a lot of work with is this Advocacy for Global Health Partnerships. And they put together this brochure declaration. And it states, we, the undersigned, call on the international community to make every effort to maximize the value and minimize the harm of short-term engagements in global health. We urge health professionals, educators, faith-based organizations, non-governmental organizations, and other entities that participate in these short-term engagements to do so with awareness of the challenges and concerns, with due respect to all concerned, as well as the responsibility of upholding social and ethical standards. And so they've laid out, I think, 6 or 7 different standards of practice when it comes to these type of engagements. And I think that they explore these risks, and they also propose ways to avoid them and how to avoid them and to do things better. And I just like their approach. I really like the work that they're doing. I would encourage if anyone's involved in the global health work, or even working in domestic environments where the communities are vulnerable, populations and underserved, I'd recommend you, if you haven't, to become familiar with the Roche Declaration and maybe reflect a bit as you read through these different standards of practice, because I think they really challenge us as medical professionals in a lot of positive ways. And I just listed some of the other organizations that have signed on to this declaration that may be familiar to a lot of the audience. And these organizations are really trying to implement some of these standards into their work around the world. So what's the solution? Obviously, this talk, I wanted to focus on capacity building, and I think I'm preaching to the choir. I think we all would agree capacity building is the way to go. The problem is it's so hard. Capacity building is defined by the United Nations as the process of developing and strengthening the skills, instincts, abilities, processes, and resources that organizations and communities need to survive, adapt, and thrive in a fast-changing world. It's really about changing mindsets and attitudes and systems. It's just hard, and doing this at an individual, institutional, societal level. It's just hard, and it takes time, and it takes an additional awareness and expertise that we don't always get in our clinical training. And but this is really, if you want long-term sustainable change, positive change in a lot of these communities around the world, this is what's needed. And so my journey and I would even call it my transformation from kind of that clinical mindset to more of a broad community-based mindset really started when I went back to school and did the MPH program here at UW, and started learning more about these issues related to, poverty, injustice, community development, capacity building, et cetera. That's really where I started learning about these ideas. And at that time, part of the program was to do a fieldwork experience. And I got connected with Hillside Healthcare International. And at that time, there were several UW physicians and PAs that were involved with the board of directors. So I sat down with them and just said, hey, listen, I'm a physical therapist. I'm getting trained in public health. What can I do for you down in Belize? And they kind of looked at me and was like, I don't know, what can a physical therapist do? We need you, but we just don't really know how to use you. And so we agreed for me to go down and do a needs assessment and really kind of learn about what the needs are for people living with disabilities and their families, and also map out the assets in the community and really learn about who is doing what and what assets and what resources are currently available and what gaps exist and how can Hillside address some of those gaps. And so that's what I did. I went down. Fortunately, I was supported by the LACIS, the Latin American, Caribbean, and Iberian Studies program here on campus, and UNICEF. They helped fund my work, and I was able to put together a report that I was able to give back to Hillside and some of the other entities and organizations in Belize at that time. And we set out, I think what I learned, Hillside was very kind of medical model based, very primary care based, which is great and important. But when it comes to rehabilitation, that clinical approach just doesn't meet the need. WHO estimates that only 2% of the people that really need rehabilitation get access to it when you approach it from a clinical model. And so I learned more about this community-based rehabilitation approach that WHO uses in a lot of communities that are underserved and low-resourced. And this is really the way I summarize it: is you treat the community, not just the individuals that have disabilities. And you really try to find ways unique to that community that can help them maximize their physical and mental abilities and help them improve access to healthcare and other services so that they can achieve full social integration. So that's the approach we took. We still did some clinical treatment of patients, but we also were working at that community level. I just felt like this was the best way to really make long-term investment and change and to build capacity in the local community. And so that's what we did. And our goals was to really make this an Indigenous-led program. We really wanted to treat the community first and patients second, which is it's easy to say, but it's hard to do, especially when you rely in the early stages on international volunteers. Because a lot of volunteers that come down are clinicians, and our comfort zone is treating patients. And that's where we're trained, and that's what we know, and that's where you kind of fall back to And we had to resist that temptation early on and really stay focused on that community level, and collaborating, developing those partners with the various government entities as well as the non-governmental entities as well. And ultimately, our goal was to address the needs of persons living with disabilities, but also address the needs of the community and to plant seeds. And what I mean by that is, I just recognized from the very beginning that this wasn't a problem specific to Punta Gorda or the Toledo district of Belize. This was a national problem. And eventually, we wanted to take our work here in the district level and really make change nationally. And however long that was going to take, we were in it for the long haul. And so we wanted to plant seeds whenever and however possible, while we were starting these grassroots changes down the Toledo district. And fortunately, and so we did. This is the CBR matrix. These are the different aspects of community-based rehabilitation that different programs address. And we try to address, over time, we've addressed various aspects of this community CBR matrix. And we partner with other organizations to support them who have other strengths and resources for some of these other aspects of the matrix. And we've studied our work, we've studied our program, we've published our findings in different journals, just to hold ourselves accountable and to ensure that we're actually doing what we set out to do. And we've had some nice success at the publication route of things as well. Our program, I think, really did ignite a lot of things down in that district. We've had a lot of success over the years. So I will say this program was started back in 2010. So we're about 14 years into things. And it's taken a long time to really make change at the district level, but we've had some success. And I'll share one program that we've worked with the Ministry of Education on that we're really proud of. Early on, right from the very beginning, the people that I talked with during my needs assessment, I found this group of parents, group of mothers really, that had children who were in school that had disabilities. And they just saw their children really being treated poorly. And they just felt like, to make lasting change, we have to reach those kids at an early age. And so they said, we need to get into the schools and we need to start doing some programming, what they called to desensitize the students. And so they helped us develop this hour-long program where we would go in and talk to the students about, hey, listen, there's other kids in your class that maybe walk different than you, maybe move different than you, maybe sitting in a chair all day long, but they're super smart and they're just as motivated as you, and they have dreams and aspirations just like you. We need to treat them better. And so that messaging we took to the schools and had a lot of success with it. It was very well received. And at first, it was just our team and our rehab director and so I brought down students from UW here early on, and then Hillside also would go into the schools to do this programming. And over time, we were able to get to all 50 plus elementary schools in the entire district, which was really great, but really took a lot of time and energy. The Ministry of Education approached us and said, hey, listen, essentially, we want to put you out of a job. If we really want to do this right, this needs to be curriculum that's taught on an annual basis by the teachers and principals. So what we need to do now is to start doing more training at the teacher level and the principal level. And that's what we did. And the ultimate goal was, again, to put us out of a job in a sense, and to be able to take this program and hand it over to the Ministry of Education and the teachers. And that's what we did successfully. And so now that program is led by the Ministry of Education and implemented through all the schools in that Southern District, which is really exciting. We also try to do a lot of work through the Ministry of Health and Wellness and really try to work with them within their strategic plan and try to nudge them when possible to not forget about the people with disabilities and try to help them implement some programming at the district level through the Ministry of Health specific to people with disabilities and to build up rehabilitation. And some of the work we've done have been some training with the community health workers, try to build up some capacity in them to at least screen for disabilities in kids and maybe do some basic educational stuff with the parents and family members. So that's been successful. And of course, we've worked with a lot of the non-governmental organizations and really viewed them as partners versus competitors and tried to get out of our silos and really try to collaborate so we can maximize the resources rather than compete for them. And so we've had some nice programming alongside some of the different non-governmental organizations in the district as well. So our work And again, it's not just our work and our impact, but there has been a lot of progress at the national level. And I'll just kind of summarize some of the exciting things that have happened in the last few years. The government now actually has 1.5 PT positions that they fund in their national hospitals. The National Hospital in Belize, as well as the Northern Regional Hospital, where they have 1 full-time PT up in Belize City and 1 part-time position up north there. And we just see this as actually a big success, that the government is actually starting to invest in physical therapists and actually hire them to do physical therapy. So much more is needed and can be done, but this is a movement in the right direction, which has just happened in the last few years. In 2021, there was a National Disability Conference that was actually initiated by the government, the federal government. And they reached out to the non-governmental sector and said, hey, let's get together and figure out how we can do more for people living with disabilities in Belize. And this is a really highly successful conference that I was able to attend, fortunately. And unfortunately, we were experiencing some of the hangover from COVID, so it's all done by Zoom. And but it still was successful, and again, movement in the right direction. This National Resource Center for Inclusive Education, NARCI, is a division within the Ministry of Education, where they're responsible for curricular development for inclusive education around the country. And they've actually taken our desensitization program down in Toledo, and they're now trying to find ways to implement it throughout the entire country, which is really exciting. My Fulbright work gave me a lot of access to the U.S. Embassy, the Ministry of Health at the national level, the University of Belize. I was also able to bring the workforce of physical therapists together, and we now meet on a regular basis. And we're trying to figure out ways to advance the profession, position us better within the Ministry of Health, and just really build capacity at that professional level. And our big goal right now by the end of the year is to establish a formal physical therapy association in Belize, which I'm optimistic that we'll be able to do. And then one of the most exciting things that just happened literally just recently was that there was the first ever bill introduced into the government aimed at strengthening the rights and enforcement of rights of persons with disability, and introduce a national commission that will ensure adherence to the laws. So this is a Belize Disabilities Bill. Actually is a bill aimed at getting the government doing what they're supposed to be doing, what they were doing 24 years ago, and actually creating a national commission to oversee this and to hold them accountable to doing more, which is really, really exciting. We're optimistic it will pass. It's just not formalized yet. But again, a huge step in the right direction. And then finally, I'll just share one last story. It's kind of ironic, but the First Lady, Miss Rosanna Briceño, she needed surgery, and this is a known story around the country, but she needed surgery on her foot, and she went to Florida, had surgery, and had 6 weeks of physical therapy after, and just had a great experience. Came back to Belize and just thought she would continue her physical therapy. Well, she had a tough time finding a physical therapist, and she was appalled. She was like, how can we as a country not be able to find a physical therapist? When we have surgery, we need physical therapy. Something needs to be done. So it was her mission. This was about 6 to 9 months ago. She brought together the director of the Public Health and Wellness for Belize, the director of Hospital Services and Allied Health for Belize, myself and a couple of other people heading up some of the non-governmental organizations. And she sat down and just said, all right, what's going on here? And what can the government do? And they just wanted to hear from us. And we were pretty direct with them. We told them how it was and what needs to be done. And at the end of that meeting, they welcomed a proposal of what it could look like for the government to actually do something at a national level. And we put a proposal together. We aimed really, really high. It was a $250,000 budget associated with this proposal. And unfortunately, it didn't get accepted into the budget this time around. But again, it's now on paper. They now know. We're going to try again and again and again and modify it if we need. But we feel like we finally had the attention to some very powerful people in Belize, and now we're not going to let them off the hook. And so we're optimistic that good things are going to change at that national level here in the next 5 to 10 years at most. And there's also talk at the University of Belize and starting some training programs and things like that specific to disability. They just literally opened up a medical school this fall. And so once that's up and running, the dean is really interested in exploring some of the other allied health professions and how we can start building capacity and building some training programs to build that workforce as well. The problem is they need jobs, so we have to address that with the government. But there's also talk at the educational level, which is really, really exciting. So finally, I'll expand out a little bit broader here to the regional level, the Caribbean and kind of Central American region. We feel like there's some things happening at that level, which gives us a lot of encouragement to keep fighting the fight. And the examples are my work and my Fulbright work, the data that I found, like I said, Pan American Health Organization, World Physiotherapy. So World Physiotherapy is kind of the body that oversees all the national physical therapy associations. And they do a lot of work advocating for our profession around the world. And so PAHO and World Physiotherapy had no clue what was happening in Belize from a rehabilitation standpoint. They had no idea how many people, how many workers there were, what services were being offered, nothing. And so we were just kind of this unknown entity. And so my work in my Fulbright was able to provide them now with that data, kind of the workforce data that they really needed for strategic planning purposes. And now they can take that data and implement it into their strategic plan to really hold Belize accountable for that Rehab 2030 vision that WHO has carried out and charged countries around the world for doing more for rehabilitation in country. So it's really exciting that those two entities were on the radar now, and they're going to help us any way they can, which is exciting. And then finally, CARICOM, which is an organization of a bunch of countries in the Caribbean and in Central American region that come together in a variety of different capacities. And one of the things that they recently did was they are proposing the Single Registration of Professionals Act. So this is an act where if you get licensed through CARICOM, you can go work in any of these participating countries. And physical therapy was actually listed on this act. And so they approached us to get our opinion on what we thought of this act. And is it good for Belize? Is it not? Is it something we would support or not? And while we didn't have any influence in this being developed or anything like that, we just felt like the fact that they approached us and asked for our opinion meant that we are now on their radar at that regional level. And again, just gives us optimism and gives us hope for the hard work that we've been doing all these years is really making some headway, and it's worth continuing. And so we feel like, all the progress we've made at the district, national, and regional level really is just kind of affirmation that we're on the right track and that we'll continue what we're doing. And so to finish things up here, a lot has been achieved over the past 15 to 20 years, but obviously a lot more needs to be done to really build capacity at the individual, society, and national levels. And we still need that volunteer industry, unfortunately. We still need it, right? The clinical capacity is not there. So we still need volunteers, but we need the volunteers working within the healthcare system that exists. And we need volunteers working in an ethical and responsible way so that we avoid kind of that undue harm that we all want to avoid. And so we need to do it, but we need to continue to build capacity, develop communities, and really continue working in this varied way to really build capacity within the rehab professions and to really build capacity within the community of people with disabilities as well, and their families as well. And it really does take a community. And so I want to end on this idea of it takes a community to do this. And I know you all know this, but I just want to make sure you guys hear this loud and clear, because I don't want to come off on this talk like I'm the one that's done all this. I'm the one that did the Fulbright research. I'm the one that started the CBR. It wasn't me. My Fulbright work to me was just an opportunity to magnify and amplify the voices of the people that are doing the work on a daily basis. Even my needs assessment, I view that as a larger voice that I can give to the people really living in Belize full time and doing all the work that they're set out to do. And so this slide here just has a picture of some of my very close friends, mentors, and people that have been really instrumental in the development and progress that we've made over the years. And I just want to give them a platform at this time and just honor them with the hard work and wonderful work that they've done and continue to do in Belize. And so this is my opportunity. So that's all I have for you today. Thank you for your time and attention. And I think, what time is it? I think we have 5 or 10 minutes for questions if we want. And again, thank you for giving me this opportunity to share my story.
Thank you so much, Dr. Hartman.